started? Good afternoon or good morning, good evening, everyone. Welcome to the second webinar from the Preventable Project. Today's webinar is about exploring the psychological and social support needs of people living with rare tumor risk syndromes, which I will call RTRS from now on, and discuss how the healthcare systems, how policymakers, patients' organizations, healthcare professionals can work together to ensure that we can have a more person-centered, standardized, and harmonized approach across Europe when it comes to the psychosocial support of people living with RTRS and their families. This session is part of the Preventable Project, which is funded by Horizon Europe. And I'm Marta Marques. I'm an assistant professor at the National School of Public Health, Nova University of Lisbon. My background is in health psychology and behavioral science, and I lead one of the work packages on the Preventable Project that I will be presenting in a few minutes, addressing barriers and facilitators to the uptake and referral of care pathways in RTRS. We are delighted to welcome a panel of experts that represent both patient advocates, policymakers, and oncologists and clinical teams and patients. And this valuable experience and knowledge and insights from different perspectives is really crucial to be able and to ensure that we have good and appropriate care in terms of psychosocial support for RTRS patients and their families, of course. We're also excited to have a broad audience joining us today. We have healthcare professionals, we have healthcare researchers, patients and their families, and we really look forward to your engagement throughout the session. So just a couple of notes before we continue. You have a Q&A function that you can access to post your questions during the webinar. As you know, we were going to have a session and a panel discussion, and after that, we'll open for questions from the audience and discuss those. So we'll do our best to accommodate as many questions as possible. And this meeting is being recorded and will be made available in the Preventable YouTube channel. So in terms of agenda, we will start with a few words from Carla Oliveira, who is the coordinator of the Preventable Project and who is going to do some opening remarks about the project and the topic today. Then I'm going to do a brief presentation about the work that we are conducting in relation to the analysis of barriers and facilitators to care pathways. So looking at how behavioral insights can inform patient decision-making in RTRS care. Then we'll have a panel discussion with Dr. Isabel Fernandes and Jennifer Perry that I will introduce when we get to the panel discussion, and also with a short video from Mariska. Then we will have 15 minutes more or less for audience Q&A and some closing remarks. And I'm really enthusiastic about this hour that we have together. So without further ado, I'm going to ask Carla Oliveira, which I think is already here, to address us a few words. Hi, Carla.
Hello. Hi. So it is my pleasure to be here today to introduce this seminar together with Marta and the team involved in organizing all the webinars. So thank you all. So I have been coordinating this project. It is my pleasure to work with such a multidisciplinary team. Our major objective is to understand the costs and the pathways of care of patients with very, very rare tumor risk syndromes. So besides that, which we are really achieving at a fast pace, which is contextualizing the clinical pathways of care with the funds that are allocated to either prevent or treat disease, we have the obligation, the moral obligation to deliver knowledge to our patients and to understand how do they react to the clinical procedures that we direct to them in their pathways of care. So I'm really thankful to Marta and everybody in this panel to discuss this and to discuss the impact, the psychological impact of the procedures we offer to patients in this setting, and how do patients react to whatever is done in their pathway of care. So thanks a lot and good luck for the webinar.
Thank you, Carla. Thanks. Okay, so I'm going to start with a presentation about the work that we are doing at the moment to understand how behavioral science and behavioral insights can help with decision making. So I will share my slides. Just give me a second so that I can open them. And this presentation that I'll be doing will also open the floor for the discussion with the panel and for the discussion from the audience, because it's a really good kickoff about looking at the work that is focusing on aspects related with psychological and social care, of course. Okay. So we know that decision making for people living or diagnosed with RTRS and their families, it's obviously shaped by a multitude of factors. So we can't say that there's only one aspect that will influence decision making. And many of you in the audience, of course, know this. So we can have aspects related with health literacy or fears and anxiety and other emotional states that people might be facing. We might have aspects related with trust in healthcare providers or the social networks, or aspects related with impact on daily life from different treatment options, for example. All of these factors will, of course, influence how people with RTRS or their families or those that need to do certain procedures or tests will accept, follow recommendations, or think about those options together with their networks and their healthcare professionals. And one thing that is really important is to think about how do we address all of these factors? How do we identify them? And how we can ensure that we address these different factors for different people to be able to help them make informed decisions and, of course, adopt the treatments or recommendations that are most appropriate for their situation. So, using a behavioral science approach can help us in identifying and effectively support the choice of people with RTRS and their families, because we can use behavioral science models and psychology models to identify specific barriers and facilitators of this individual decision-making process. There are various models that can help us in understanding what are the different influencers or determinants of behavior. One of the main models there that is currently used, so very widely adopted and very useful even for people that are not psychologists by background, but are different professionals or people wanting to use this model to understand their behaviors or others or their behaviors, is the combi model. Capability, opportunity, and motivation model that you see on your screen here. This is a very simple integrative model that basically tells us that any behavior, whatever is the behavior, from health to climate related behaviors to safety to school to learning to personal behaviors, any behavior that we engage in is influenced by different barriers or facilitators that fit in three broader categories. So they are influenced by aspects of capability, if we are physical capable of engaging in the behavior, or psychological capability, aspects such as knowledge. They are influenced by our motivation to engage or not engage in the behavior, and they are influenced by aspects related with the physical environment and also the social environment. So just a few more details here. When it comes to capability, for example, for patient decision making as a core behavior, we can have aspects that will influence positively or negatively the decision that will be made by the patient or the person. It can be influenced by aspects related to our knowledge. How much do we know about a certain disease or a certain procedure? Do we understand the information that is given to us? It might be related with aspects related with skills. Do we have adequate planning skills to be able to engage in the behavior? Are we able to process complex informations? Are we physical capable of doing that procedure or that treatment or that appointment, for example? If we move to opportunity, aspects such as access to specialized centers, emotional or instrumental support, costs, access to information, or some of the core elements from the physical and social environment that can influence our decision-making processes. And when we move to motivation, we can have aspects related with our beliefs about the benefits of risks of engaging in a certain care pathway, for example, our risk perception. So how much do we think we are vulnerable to a certain condition, and how much do we think it can affect us? Our confidence and trust in clinical teams' recommendations, for example, our social norms, so what we think other people think about that, and if we are making decisions autonomously because we want to, or if we are feeling pressured to make those decisions. So using the COM-B model of behavior as our overall approach within the preventable, we have a dedicated work package looking at a behavioral analysis of the uptake and recommendations of care pathways for RTRS. So this work package has three main objectives. The first one was to do international survey looking at the factors influencing the choice of care pathways for patients with RTRS and for the clinical teams across the countries that are part of the Preventable Project, and I will mention that in a bit. And we had two different surveys that data was collected from. Based on the results from this survey, we conducted focus groups with the clinical teams, patients with RTRS, and the patient social network to go more in depth within that COM-B model factors. For those that were core in the survey results, we conducted the focus groups to explore those factors in more detail and understand barriers and facilitators in more detail. And both of these bits of work that we have already conducted and analyzed, and I'll just briefly present them today, just focusing on the patients, are going to inform oops, sorry, this blocked, are going to inform guidelines that we are current developing to for patient-centered communication, for decision making, and for discussions in terms of care pathways for clinical teams, and that we expect to do different forms of co-creation and consensus approaches to be able to develop these guidelines. I just wanted to raise that the protocol for this work is currently published and available, and we can of course share the QR code and link after this webinar if useful for people. So as I mentioned before, we conducted an international survey using the COM-B model as a basis to look at the behavioral factors influencing the care pathway choices for RTRS. So we had, of course, some socio-demographic characteristics. We looked at barriers and facilitators, and we ranked the barriers and facilitators in terms of their importance with this questionnaire. The questionnaire was hosted online, and it was filled by people in the countries that are part of the Preventable Project, so clinical teams from the hospitals that are partners in the project, and patients. And we disseminated and collected data through different patient associations, through Gentouris, through the clinical teams that are part of Preventable, and from other databases of stakeholders we had access to. This is just an example of how the survey looks like. So very briefly, what we found, we collected data for 254 patients. 71% were women. And you can see the distribution here by country. So we had a large percentage from Norway, France and Germany, then Spain, and then smaller samples from the Netherlands, Portugal, and other countries. And we had a distribution between different types of RTRS, so rare syndromes, with a high percentage of Birt-Hogg-Dubé syndrome. But you can see here that we had a distribution by all the syndromes that are part of the Preventable Project and that are described in full detail below in the slide. So in terms of what we identified as core elements that were scored higher in terms of being relevant from the different categories. So we could see that aspects like being physically capable of engaging in a certain care pathway was an important aspect, but we can see that aspects related with the knowledge about the care options, access to information, aspects related with social opportunities, so support from others and relationship with the clinical team, as well as aspects related with reflective motivation, so beliefs regarding the positive benefits of a care option and involvement in the clinical decisions were aspects that were really important and that were classified by the patients. When looking at main barriers and main facilitators ranked, what we saw was that lack of knowledge about the syndrome, lack of understanding of care options, fear of life changes related with care options, and poor communication were the main barriers that patients ranked as preventing them to engage in a recommended care pathway that their clinical teams was making. In terms of main facilitators, knowledge about the syndrome was an important aspect. Understanding care options would help them in making an informed decision. Knowledge about the side effects and what is expected in terms of impacting their lives, and trust in the clinical team. So we can see that a lot of the facilitators are, in certain cases, the opposite of the barriers, and also good communication with clinical teams. The trust aspect is quite important, that showed up as a facilitator, although it wasn't in the barriers. So based on the results from the survey, we conducted focus groups in all the countries that I mentioned before. So we had 36 participants, half of them were women, mean age 47.5. And from these focus groups, we had a lot of segments, so the bits of texts that are transcribed from the focus groups that were coded. So we had 850 segments because we did had a lot of participants and focus groups with clinical teams, patients, and social network. These results are just for the patients. And we could see that the core aspects that were coded and that showed up were related with the psychological capability, so knowledge and skills, followed by reflective motivation, so their beliefs about treatments, about impact, about benefits or risks. Then the physical opportunities, so access to care, social opportunity, and then aspects related with emotions, etc. So some examples here in terms of motivation, some of the citations we had. I'll look at the second one, for example. It always helps to be able to talk about it, especially after hospital appointments, which are very stressful. So this points to aspects related with motivation. Then the last one, for example, you put your children's health first. That's how I see it. But even if my daughter has grown up, that's it. When you're a parent, you put your children first. So a way of also justifying the concerns about their child health and risks in terms of RTRS. For opportunities, we have some examples here. The first one relates to the social network and family network. Um, um, and other aspects related, for example, the third one in relation to visits to the hospital that were not effective, were not good, the constant changes in doctors, in appointments, and aspects that can block the correct treatment and adoption of those treatments. And then in terms of capability, we have some citations here that are related with in giving opinions, giving information, knowing what to do, knowing what are the expected impact of certain things as relevant. And just to tell everyone that we are working on the publication of this study, and all the citations, all the codes, everything that was done will be made publicly available, of course, anonymized and following all GDPR procedures. So people can explore it and see what we found and how we coded and how we analyzed it. So just some very brief conclusions, and then we will move to our panel discussion. Um, in terms of aspects related with this study that are relevant for action and for the guidelines and for person-centered communication that we are building, and also looking at policy and psychosocial support, it is really important to think about how we can co-design decision aids with patients. So how can we together think about what is the flow and of decision process? How can we help people in terms of the visuals, the type of information that they need access to? How can we build this together with patients? Think about how we can train clinical teams better in terms of doing person-centered, transparent, empathic communication. involving the social support networks in the care process at all stages, simplify access to specialized care, integrate health service to prevent fragmentation, and ensure that psychological and behavioral support is present at all stages of the process. And this is one of the main aspects that we are discussing today. I just wanted to acknowledge the work of everyone involved in the Preventable Consortium and everyone that participated in the study, but in particular, the researchers that have been involved in this work and have done an amazing work from our team at Nova University. Okay, I will stop sharing my slides now and we will move to the panel discussion. Just a reminder that please put your questions on the chat. We will address them. So I would like to start by introducing the panelists first. So we have Isabel Fernandes, who is a medical oncologist, a colleague from Nova University, so a researcher and assistant professor at the Nova Medical School. Also works, of course, in a hospital as a clinician in oncology, and very recently was nominated director of the National Program for Oncological Diseases at our Directorate General of Health, which is our equivalent to public health departments in other countries. Welcome, Isabel. We are delighted to have you here with us today. And I would also like to welcome Jennifer Perry, who is the president, co-founder, and patient of the Li-Fraumeni Syndrome Association in the United States. Thank you, Jennifer, for your availability to be here with us today. So we'll have about 20 minutes for a panel discussion with a few questions that we have prepared. And we will then open the floor for questions from the audience and also show a video from a patient representative that couldn't be here with us today. And I will introduce right before the video. So Isabel, I will start with you, if that is okay. As you know, policymakers have a crucial role in ensuring that support in terms of psychological needs and social needs can be embedded in the healthcare systems, both in plans for oncological diseases, but also thinking about how care pathways can be more standardized. Of course, this will vary according to the healthcare systems. It can't be equal everywhere, but there are things that we can think about in terms of making this a more standardized process and how policymakers can think about the sustainable approaches. So, from a policy perspective, but also from your experience as an oncologist working for many years in the national healthcare system, both public and private, and in universities, what do you think are the main steps that the national healthcare systems can take to better integrate specifically the psychosocial support in the RTRS care pathways? How can this be better integrated in terms of communication, decision making in the care pathway at the different stages?
Okay, thank you. First of all, I would like to compliment all the participants and the person that are viewing this webinar. It's a pleasure to be here. Of course, the psychosocial support is very important for patients, and in cancer specifically, it's almost mandatory, and we know that already. Even persons that say that I don't need anything in certain aspects of in certain aspects and in the pathway of the disease, they will need it sometimes. And what we want is to include this kind of support since the diagnosis until onward. I don't know. It depends on the patient. It depends on the disease. It will depend for how many years the patient will be in the departments. But more than that, the patient, after having an oncological disease, probably they will need some support also. And in our national cancer strategy, this is already, we already thought of that, and it's already published. So we want to find the gaps see what we have, what are our resources, try to find out what are the needs for the patients, and what are the missing points that they already say, and which are the departments that have this kind of support or not. And then we need to design the models. I think this is for our National Health Service and for other countries also. First, we need to see the reality of the countries, and then we need to design the models. After this, we need to try to implement, but for that, we need to train the people. We need the training. And we need more than that. It's very important to communicate and maybe to do some actions of literacy for health professionals and for patients, for them to understand that this is a support that is necessary for them to live better, to live with better quality of life, to have emotional well-being. And of course, after the implementation, we need to monitor. So we need to do prompts, so to have patient report measures to see what is missing in the models that we already implemented and to change it. So I think this is not only for Portugal, it's for all patients with cancer around the world, namely in Europe, because our national strategy was done based on the Europe's Beating Cancer Plan. Of course, we adapt to our reality, and we really know that in our departments, in the National Health Service, there are departments that have this very well established, but there are other departments of oncology that don't have it. And sometimes it's not very easy to access to this kind of support. So I think first we need to see the realities, the gaps, and then design what we need.
Thanks, Isabel. Just asking a follow-up question on two things that you said. So this last one that you said in terms of sometimes it can be difficult to access that support. And we know, I mean, I know better the Portuguese reality, of course, but we know that there aren't enough psychologists for everyone. And we might need to think about how can other healthcare professionals provide some kind of support, like a step cared approach, for example, and be more trained for that. So I would like to have a bit more of your views on that. How can we involve others or integrate that?
In oncology, we work in multidisciplinary teams, so we don't work alone. And I think the health professionals, including psychologists, psychiatrists, and other social workers, and so on, should be included in the meetings. It's very important to standardize the communication between all the intervenants in the healthcare, and for everyone to be aligned, how to communicate, how to support, and how to prioritize, since we don't have the possibility of putting everyone at the same time. The psychologists are not so many in the National Health Service. The psychiatry is the same. That most of the times they are more with the psychotic patients and not so many. There aren't so many for the oncological patients. But we need to prioritize and to see, and if everyone is included in the multidisciplinary meetings, we can give some support, and then the patient maybe can wait a little bit more, or if it's more important to put in at first and in a quicker way to allow the patient to have the support for not only psychosocial but also behavior support for emotional well-being. There are another point that normally is not talked about is the families, because we know that sometimes it's not only the patient, it's the families that also have some issues, and we are not being able to put the families in this kind of support at the moment in the majority of the departments. But when we are, for instance, speaking about RTRS, we know that the families need also some support.
Mhm.
And I think it's important to think about that.
That's a really important point, Isabel, and I will go back to you afterwards. But follow on that, I would like to ask Jennifer a question that is related with that. So, Jennifer, we of course know that living with RTRS or any other, of course, chronic disease will affect physical health, but also emotional well-being, and in this case, is the entire family dynamics, as Isabel was mentioning, and daily life. So, of course, having patient-led and family-led initiatives can be crucial in finding more effective ways of looking at psychosocial support. So, in your experience, how important do you think that? So, Isabel mentioned this as an
Yeah.
oncologist, importance of the patient network and the family network and the peer networks, if we want to be a bit more inclusive on that. How important it is to address these unmet psychosocial needs and supporting the emotional well-being of the patients and their families. And of course, how you think that healthcare professionals can also support these communities even further to strengthen their links and how they can help each other. Thank you, Jennifer.
Yeah, no, this is extraordinarily important, as you can imagine. And what Isabel was talking about, not all centers and hospitals have the bandwidth or the team to provide some key support. So that adds just like another layer, if you will, another dimension that makes this even really crucial. And we have found, particularly over the last 15 years since we've been formed, that patients do have varying needs, and if they're not met, it can really impact their outcomes. It can impact a lot of different things. And as she mentioned towards the end there, not only do patients like decide they don't want to go to appointments because they're afraid, they're nervous, so they stop going to appointments. Screenings, as you know, can be very important for rare diseases and syndromes and stuff like that. And so not only does it affect the patient, but as she mentioned at the end, we have found that it truly severely impacts the entire care team for that patient as well, whether it's immediate family, friends, whoever's involved in those patients' lives. So it really impacts a whole group of people. And so that's why it is very important that we have this kind of safety net and this kind of care. In terms of the healthcare professionals, we realized several years in, probably maybe like four years in, that we had to have some kind of structure in our organization, as young as we were, that really helped support this, because the patients don't have the expertise. We have the heart, the willingness to try to support our patients, but there's only so much we can do. However, peer-to-peer is critical. So what we did is we formed a genetic counseling advisory group, which was really important for us. So not only were we able to triage questions that patients may have, and we're able to get answers back very quickly. Usually within 24 hours, we have a team of genetic professionals, counselors throughout. We have 12 international chapters. So we have them around the world because we are a global community, as rare as we are. And even though it's not a genetic counselor, it's someone of an equivalent. It can be a social worker, it can be a psychologist. It's just someone that has that expertise in that field. So we're not, I don't think the title really matters, if you will. It's more getting the right people together to actually support the patient. So we have that kind of group also, but they also work together. We have projects with the Genetic Counseling Advisory Group. And what's really important about that is as we work with patients continually, we prioritize what are some of the most important needs at the moment. And then we create projects to identify those needs and hopefully get some solves, some solutions. It could be as simple as an FAQ sheet on how to handle coverage. I understand in certain areas of the world it's covered. Sometimes the waiting, though, can be tremendous. So there's really different concerns throughout the world for different things. And this group having it built throughout, that I call it the silver lining, having a global community with LFS throughout the world. That's why we have different chapters. It's really important to be able to identify the needs throughout the world, because every country has different governing bodies, different complexities. But I will say the one thing is that we have in common is, we all want the same thing and we all want support. So we work together to make that happen. But having even if it's a very informal structure with partnerships, and I really call it partnerships, you have to have people that are committed to helping in that way. And I really think I can't imagine where we would be right now if we didn't have the partnerships and formed that group, because there are just so many different needs that need to be addressed. And I think it takes a little bit of a burden off, quite honestly, like the physicians. We have some countries that don't have genetic counselors, psychologists, things like that. So they're kind of the person handling all of that. And that's quite a burden for a physician. I can only imagine having to handle the medical piece, the psychosocial piece. It does alleviate some of that. And we're actually in the process right now of forming an addition to our genetic counseling advisory group. It's called PSAG, so our psychosocial advisory group. So in the process of forming that team right now, we identified that at our last symposium in October. So it's critical. It really changes outcomes.
With your experience with all of those initiatives and with the association that you're leading, if we focus specific on embedding psychological and social care in different systems, what would be your main suggestion, or what do you think would be the core aspect that should be targeted?
Um, that's actually a very hard question to address. And I can only imagine every rare syndrome. I'm not sure if everyone um, has necessarily even formalized groups, right? I remember back in 2010 when they brought 100 patients in, there was only like 500 in the world at the time with our syndrome that was known to be tested. And they just asked us to form some kind of group. So I think one of the most important things is, even as informal it is, if you can get a few people, no matter how rare it is, and I work with many rare groups that only even have like a handful of people in their group, it's that rare, it's okay, but I think someone needs to kind of like lead the charge in this aspect. And then you need to partner. You just need to get a few people that are willing to partner and help and volunteer in that capacity. So again, we have a lot of centers in the US that don't even have the knowledge of LFS, like they're not centers of excellence, if you will, in that. But that's okay. Now they have a group of professionals that understand LFS very well, and they have access to it too. So it not only helps the professionals who may not, in centers that may not really specialize with LFS, but they can get the answers and the treatments for their patients and the guidance, as well as the patients now having that connection. And I'm not sure how it is in Europe, but in the US, patients have access to the results very quickly now. So in their patient portal, they have access a lot of times before the doctors even see it before the end of their day. So that has added a very big dimension for us. And it's, what do you do? A patient finds out their results. They have no idea, number one, what they mean, how it affects them. What does this mean for them personally? Now, there's a lot of stress and anxiety that has been like an additional layer as well. So I would say asking a rare group to form some kind of thing, and then asking some professionals to partner with them and kind of formalize that a little bit. Because I think that's really important, because then at least you have a known pathway. We have a simple 800 number that we use for that, but we just have in the background, like I said, 2 or 3 professionals. We have a simple info line that people can ask any questions to on email. And then we ask the professionals and direct it. We don't answer like my case questions, if you will. So it doesn't get too personal, because we certainly wouldn't want anyone to overstep anything that their own professionals are saying. However, it can certainly give basic things, lead them to the correct resources, and connect them with centers, professionals who might have their syndrome. Because a lot of times they're getting diagnosed with this stuff, and they're maybe getting diagnosed in a center that may not specialize in this, if you will. So, but that's what I would recommend, is formalize some kind of pathway, no matter how rare it is.
That's really important, Jennifer. Thanks for sharing that. Isabel, I would like to just ask a question following up on this. And Jennifer mentioned the importance in terms of having this connection with the centers and having this more structured approach in a way that can start, with the patients and then the healthcare professionals, but being sure that there is a process that is in line and that includes people with RTRS and their families from the start. So I just want to ask you, Isabel, how feasible do you think it is that in the next few years we can actually move towards having this more structured approach where the involvement of families and patients and integration of care is actually formalized and is addressed more clearly in the guidance that is provided to the different clinical teams? You're muted.
I think that is feasible, but it won't be easy because we have a lot to do. Of course, we have already certain things related to this, but it's not enough. And it's necessary to guarantee the sustainability. And we need to see what would be the costs of it. And for that, we need to have measurable targets to decide. More than that, if we need a new workforce capacity, that's what you are asking, we need specialists, trained specialists, namely nurses, psychiatrists, psychologists, a lot of people that need to be trained and need to be paid. And the only way to do it, and I'm thinking now about that, is that we need to have government forums, because it's not only the Ministry of Health. We need the Ministry of Finance, the Ministry of, we need several ministries to see if that is possible. Probably it's necessary to have first pilots and to see and to try to implement the models after seeing what is feasible or not. I think it's feasible for 2-3 main cancer centers in the next years. But generally, everything what maybe people need, people with cancer need, it won't be so easy. However, when we are thinking on rare syndromes, I think we should centralize them. And we need to have 2 or 3 places. Portugal is not as huge as other countries. And maybe we can centralize and to have this for these specific groups. But when we are thinking in giving psychosocial and behavioral support, we are thinking not only for hereditary cancers, but for all patients with cancer. And we need to have an offer that can be for everyone. So we need maybe to have specific centers for rare syndromes, in which the models can be tested with all the patients and the patients with rare syndromes. And these are, we already have two consultations, specific consultations in Porto and Lisboa, in Portugal in this setting. But we need to measure and to have financing for it. We need to map costs, to build business cases in order to demonstrate the impact of the address, the feasibility, and it's a process. So I don't know if it will be so quickly, but we are going there. I think we are doing the pathway to accomplish our goals.
Thank you, Isabel, and thank you, Jennifer, again for your first initial thoughts. We are now going to move to a very short video from Mariska, who is the representative of the PT Association from Belgium and Netherlands. She's the interim chairperson. and we'll just show her a short video. Unfortunately, she couldn't join us today, and she will explain why in the video.
Hi, my name is Mariska. I'm interim chairperson of PT in België, Nederland. To start with, I'm sorry I cannot be there live, but I just gave birth. Very unexpected. Well, not the giving birth unexpected, but the fact that it came early expected.
It was so sudden.
It was really sudden, yes. I do think it's important though to share my/our vision of the PTN syndrome, and they asked me some questions in advance before I knew I would have given birth, so I would like to answer them anyways. The first question was, in your work with PTN patients, what types of psychosocial support have been proven the most meaningful for patients and families, and where do you see the biggest gaps? I think that's a hard one, because personally for me, I never really got help. I think for me, it's because I grew up with it. I was diagnosed when I was around 8, I think. So I didn't really have help, but I asked around at my other board members, and it's different because most of the board members have kids with PTN. And with most, I mean, it's very small, so not that big. But yeah, they also didn't got a lot of support. Some did get support, but it was more of a, okay, well, this is it, we'll see you when you need any help. And that's also kind of the biggest gaps, because sometimes you don't know what you need, I guess. And sometimes, even though it's hard to know what you need, especially if you get a new diagnosis like this, it is sometimes easier if it's at least 1 or 2 sessions. We are like, okay, this is what it is, do you have any questions? And the biggest gaps, the biggest gaps is also the fact that if you get any help, it's more like the patient, not the individual situation, the individual case. And I do think that's also important for any psychologist out there that can help, or anything. That's, they see it more as a, how do you say it? That it's always an individual case. It's not the patient. Yeah. Then I will say the other question is, looking ahead, how can patient groups collaborate more closely with healthcare professionals and policymakers to strengthen the care and ensure that patient voices are reflected in future programs and strategies? To not be scared. Patients groups should not be scared to say something, to be all like, look, this is what I know that we know our patients want. Don't be scared to go out there and ask doctors for more info, help patients to find those doctors. Ensure that patients' voices are reflected in future programs and strategies. That's also a hard one, because I talk from my own experience. And I think sometimes patients' voices, often patients see themselves as the patient, and the patient doesn't exist. Patients should be saying, look, this is what I need, and that's how your voices can be heard, to just say, this is what I need. And then the last question, from your perspective, what's the single most important action needed to improve support for people living with rare tumor risk syndrome? I think, again, a hard one, because I can say it will be important to have a line of like, okay, just like, for example, around 30 breast get exams, around 40 you will get this. And I also think that we should start finding the line of when does someone need help.
Like a baseline.
Yeah, like a baseline.
Yeah.
when does someone need help, because sometimes they don't know it yet, and sometimes it's a line. It's also for a doctor a hard line, a border to cross, because the fact that you have how do you say it? A doctor should, of course, listen to the patient, but also listen more to the individual and the subtle signs. And sometimes the physical doctors know only the physical, not the mental. Mm-hmm. And that's what also is important for doctors to help each other, the physical doctors and the psychological doctors. So yeah, I think that's it. Thank you.
Goodbye from us. Bye.
Bye.
Okay, this was a very, very powerful video from Mariska, so I will thank her later, but this was really good. So I will start with a question actually from Carla that is associated with the last thing that was said in the video in relation to what is the baseline line where help is needed or exams are needed or whatever is needed. And even before that, that has to do with carriers that are not sick yet. So a question that Carla asks here is that there is specific type of psychosocial support that is needed in RTRS that doesn't exist for other oncological or other diseases that has to do with supporting carriers that are not yet sick in terms of what is expected, what they can do, what is happening. And the specific question from Carla is, do you think, and I can also add to that after, that family consultations would decrease the economic burden of RTRS care? So Isabel or Jennifer, whoever wants to start.
Well, I would tell you, particularly in terms of LFS, which is a rare genetic syndrome, I would tell you it certainly does relieve the economic burden, particularly if we have several patients that won't get sick or won't get their cancers until, let's say, their mid-20s and on, not necessarily getting it as a young child. So knowing that you have this syndrome and then being able to get the appropriate screenings and catch things far earlier not only relieves economic burden in terms of surgeries, treatments, things like that, certainly makes it less anxious, just makes it much easier for the patient to deal with, knowing that, I hate to say survivorship, but that's really what we're talking about here. If you can catch things much earlier, their chances of survival is also much greater. So certainly having that kind of care. And I will tell you, the youth program that we have developed has given us some great insight, knowing that it's almost more stressful for someone knowing that they're probably going to get cancer soon. They just don't know when, and they haven't had it. Whereas some of the young adults who have already had cancers, like it's almost like the pressure's off. They've had their first cancer or a cancer or whatever, but it's that waiting for the other shoe to drop, the anxiety of that, and knowing that you're most likely going to get this and not having had it yet. There's that challenge too. So there's a couple different things to that. But yes, I do think it relieves the economic burden in a lot of different ways.
Yeah, and this aspect that Carla just clarified also here, that looking at family consultations instead of all separate consultations, it's a bit like the family doctor. So it's similar but specific, the same approach but specific for RTRS. Isabel, do you want to add anything?
I agree what was said, I think it's very important. I would like to add two things. First, it's very important to have reference centers for rare tumors. And if we have hereditary tumors, we need to have a specific consultation, and we need training for the people that are dealing with that. And in Portugal, I will give the example of Portugal. We have a restrictive legislation. So if I detect a tumor that I think that can be hereditary because of the history, because of the context, because of the type, etc., I I'm allowed to ask the test, the germinal test, to see if the patient has an hereditary mutation. But for the family, I need to send them to a geneticist for a specific consultation. The thing that I think it's maybe missing is if I have several persons, patient, we only have 2-3 places where they can be followed with some psychological support. But it's not so easy to integrate these people in the National Health Service because of the context.
Yeah.
But I think it's important maybe to think that these persons need to be in specific centers, in specific
The reference centers.
and reference centers with people that have know how to follow these persons to avoid the cancer and to have specific follow-ups, specific interventions like hysterectomies and so on. So we need to think about that. Maybe this can be more plausible in terms of sustainability.
Thank you, Isabel. And Carla mentioned here that we do have reference centers. That's true. I think that Isabel's point is more that they might not be enough. Sometimes even the care there might be missing some aspects, and sometimes it's difficult also for people to access the reference centers. And that's something that was also mentioned, for example, in the survey and focus groups. Sometimes a difficulty in assessing the reference centers. It's not easy for certain families and patients, of course. I'll just move to one more question, and I know we are reaching our time, but also because the call break, we lost a few minutes. There is a question here in relation to what is the biggest challenge in providing effective psychosocial support, and why it hasn't been embedded into the existing system yet. And this is from a patient perspective. I'll just say one comment in relation to this, and then Jennifer, if you want to comment, or Isabel. I do think that the challenge in terms of the effective psychosocial support is not just for RTRS. This is equivalent to any chronic or acute disease, whatever clinical condition. Psychological support has always been I don't want to say this in a very negative way, but it's always the last priority because, like the concern is we need enough doctors, we need enough medical appointments, we need enough people to provide the core treatments for curing or for survival or for management or for prevention, very few also. And then we might have psychological support. And that has been the case for many years. I think it is improving a lot. We have more and more understanding about how much investing in psychological and social support can then reduce burden and economic burden and can improve disease management. But there's always this tension between priorities, what is more relevant from a political perspective, and what we have money to afford, and what we are capable of integrating in the system. So we need to think that psychological services is something that is quite recent, so it's a process and it will take its time. This is my opinion as a psychologist. Isabel, Jennifer, do you want to add anything to this?
Yeah, sure. I would just say that one thing we've learned as a group, and actually I think a lot of the professionals, both the patients and professionals learned, I think of the three-legged stool, right? Without the physicians, without the advocacy groups, without the psychosocial piece, if one of those legs of the stool is missing, the care is not really the entire piece for the patient. And I think for us, one thing we also learned is sometimes and I'm going to include myself in this, you overanalyze, like, what's the best steps? How do we get this across to all of our chapters around the world? How do we make sure all our patients are supported? And one thing we learned is just starting to take baby steps. Although, yes, we need some real formalized things that are going to cost significant money, both in the governments and different governing agencies and stuff. It just takes a few people with some heart that are willing to volunteer. So I think you just need to think about advocacy groups who have some kind of model. I mean, our model is by no means perfect, and we're still evolving, as you know. But there's people like us who are more than willing to help. We have chapters, for example, Germany is a very, very active chapter, and we're willing to help. So I think knowing that as long as you start somewhere, you can always tweak as you go along the way. And I think the biggest and the hardest step is just starting someplace. You have partners around the world that are willing to help, but I think it's critical. And knowing that all of us are just as important, both psychosocial, physicians, patients, the advocacy groups, it's very important. So.
Yeah. I would like to add something, because we need the patients' associations with us, and it's necessary to have some literacy. If we go see the first draft of the national strategy in Portugal, the psychosocial support was not there. And but we have the patients' associations in the executive commission for the strategy, and they said no, we need psychological support. So, and it was added, and we had 4 items that were not there before. So it's an example, but because we need to know what the patients need. Because sometimes we only think in the disease, and we don't think in every aspect. When we are thinking on oncology, we want to give longer survival and quality of life. But there are other things that sometimes the policymakers don't think on. And in this setting, the patients' associations are very important to say, no, we also need this, or we also need this. And I think only with this kind of collaboration, we are able to put everything what the patients need in our strategies.
That's really important. It goes back to what Jennifer was saying in terms of also advocacy groups and patient-led initiatives. And we also found that in our study that, co-designing, co-creation of options is really important and relevant. And this also links with what Philippe mentioned in the chat in relation to also looking at what are innovative initiatives, different things that can be used that can support these patients and trying these things out. All of this is really important. So we really need to finish our webinar. I would like to thank the panelists. I would like to thank the audience. I think it was a very insightful and engaging discussion. Of course, we could stay here for hours talking about this, and we will have many more opportunities as part of the Preventable project to involve people and have your visions also in relation to how we can provide better, more efficient, look at the gaps, provide standardized approaches for psychosocial care. And as I said, we were building also guidelines in terms of more patient-centered communication and decision-making process. So it would be great to have everyone in the audience also providing their inputs to this work. So the recording will be made available soon in our YouTube channel, and there is a link here on the chat for you to fill in with your views about the webinar. I would like to thank everyone involved, Emma and the Full Preventable Consortium. These webinars are really important for our conversations about RTRS and improving care for RTRS. So I hope we will stay connected. Thank you, everyone, and have a rest of a nice day. Bye-bye.